I'm Ebony Carruthers. I am the Assistant Director of Communications for the Student Special Interest Group of the Section on Women's Health. And today I'm interviewing Tracy Spitznagle. She is the Residency Director of the program at Washington University School of Medicine in St. Louis. And I'm just going to be asking her a couple of questions about the residency today. So Tracy, could you start by telling us the basic logistics of your program, how long it's been around, how long it is when it starts?
Sure. So our residency program started in 2010 with Uchenna Osai. She was our first resident. Dr. Osai is now a pelvic health rock star on many spectrums. So you'll have to see her blog, UC Logic, for all of you that want to connect with someone who's done it and lived it and gone even further. But what was the first question? I was writing on UC.
How long is it, and when does it start?
It's 1 year long. It starts in September, but that's kind of a trick because it actually starts earlier than that because we have didactic information that gets covered. So you come into town and get settled hopefully in July. A lot of people take their boards in April in order to make the transition easier. I'm not going to say do that, yes or no, do that, because I think you have to get through your professional curriculum, and that's paramount to success in residency. So get done with all of your coursework, take your boards, and then come is what a lot of other people do. So that piece is a choice. From July, if you take the July boards, then you're going to probably go right from studying for boards to finishing up all of the coursework that's needed for the lymphedema course, because that comes first. So for us, we do lymphedema training before on-site here at Washington University, the end of July, the beginning of August. And we also have our first movement system education weekend, sometimes the first or second weekend in August, and that kind of depends on coordination with the fellowship training program. So at Washington University, we run a movement system fellowship program, and so there are educational overlaps that occur so that the resident is training sometimes with the fellows in relationship to the movement system. So that is a uniqueness within our program, so that you get exposed to individuals that are learning about movement while you're learning about movement and women's health. Your start go date for coming in and getting all the orientation to the clinic and starting clinical practice is September 1. So your benefits start popping in a month later. And that's always a question people ask is, new job, and when does my health insurance actually kick in? And you get that month of the first month under your belt, and then you can start using your benefits at that time. We have structured our curriculum around weekend seminars. And so we host the pelvic 1, 2, and 3 that the Section on Women's Health, their curriculum that they have here at Washington University. So right now, our plan is for next year, everything's scheduled on site. And the reason I say that is that so every once in a blue moon, something changes in the curriculum. So if we, for some reason, can't schedule it on site, we may have to send you to a course somewhere. And that it just depends on how we generate those contracts. So the standard is that you aren't traveling, you're in St. Louis and the courses are coming to you. We also have usually a supplemental course related to cancer care, like a second advanced lymphedema thing that we sometimes pull in the spring. Sometimes we don't. It really depends on the availability with close and the desires of the faculty as to kind of how the last time the course went and what they feel like is going to be the best for the resident themselves. This year, one of the supplemental things we're doing is in April, Susan Clinton and Rebecca Stevenson are coming in, and we're going to do some advanced pelvic girdle techniques. 2 years ago, we did advanced bowel techniques. 3 years ago, we did something related to breast cancer. So the spring always has kind of a gimme course that we're always kind of trying to figure out or test driving concepts sometimes just to see what we might do for future. So that piece we're never quite sure. Across the curriculum, the resident will participate in interdisciplinary education where they'll go and observe with a urologist, a urogynecologist, see urodynamic testing. We have colorectal surgery meetings where they have rounds and discuss complicated cases and show photographies. So we try to get you there. You observe in labor and delivery over a weekend. Our current resident, Taylor Chapman, is actually doing that this weekend. And so you literally just follow the on-call OBGYN around and watch all the labor and delivery and kind of see how that all works. So those are all kind of pieces that get you out of the clinic and layering in specialty practice from other disciplines. So Ebony, what else do you want to know from me?
So you were talking about the classwork and also being in the clinic. What's the ratio of hours of classwork to clinic time?
Sure. So we average out to about 36 hours a week of clinic care. So what we do is we have the residents scheduled for a full 40-hour work week, and then they block up to 4 hours at a time in order to get time to have participate in independent activities. Like we have a journal club, so you have to research, find the articles, and then read them and write them up. And we have kind of a take-home test kind of situation where you have to read the Irian and Irian textbook and then fill out the exams that go with that. So those are the kinds of things that you might block your schedule time for. But when we have a Friday where we have a continuing education course, that 8-hour day counts as that 4-hour time block. So there is a little bit of give and take. Mentoring is on Fridays right now. That's how we schedule it. So it's 4 hours on Friday mornings. And if we had a Con Ed course that was on a Friday, you wouldn't have mentoring that day. So those are the kinds of things that there's a little bit of give and take. It averages out to about 36 hours of clinical work and 4 hours of didactic, but some weeks are a little heavier. And then you have a lot of weekend commitments. And I think that's a piece that is hard to get used to because you're used to having more downtime. But the weekend commitments in the fall are fairly significant so that you can get through all your coursework. So you'll have 2 movement system weekends and 3 pelvic health weekends that you'll have committed. And then sometimes the residents like to participate, say, in the IPPS conference. Every other year it's in Chicago, which is an easy drive. And so sometimes they drive up for that. So there's this give and take on quality of life, time to yourself, time to play versus time to focus and learn the new materials that you can take it back into the clinic.
Okay. And can you talk about some of the clinical settings? You said that you're following a OBGYN around. So is that acute?
Mm-hmm. Right. So for the weekend that you are following in labor and delivery, you're in the main hospital here in our medical center. It's called Barnes Hospital. And then when you are going to observe with the urogynecologist, you head over to where the offices are, the OBGYN offices are. So the school is about 4 blocks off campus from the main medical center, but we have a clinic within our building that's a faculty practice, and the resident practices in that practice for their patient care at this time. So the settings are varied only in that you go and observe with the physicians over where their offices are.
Okay. And is there any research that goes on during the residency?
I think that's a good question. Right now, we don't have like a set research project that the resident is doing. This is a clinical-based educational program, so I feel it's really important that the resident learns how to synthesize the literature and educate themselves related to what is evidence-based practice. So they do a synthesis and a case report, but we don't actually have them participate in randomized clinical trial or something like that. So I feel it's important to maximize the clinical experience, and the feedback and the mentoring provides the growth related to that clinical experience.
Okay. And is there any men's pelvic floor or pediatric pelvic floor training or opportunities?
Sure. So we do get about 10% men right now. It kind of waxes and wanes. We had a strong referral source, and he just moved on. And then as his practice has been absorbed within urology, we're starting to get more referrals. I actually this week on my own caseload have 4 men, which is not usual. It's I usually have 1 in the scope of all of the patients that I treat. And so the resident will start to treat men after they've had their colorectal course, which is the second course for the section on women's health. So usually at some time, the course is in the end of September or the beginning of October, depending on the timing. So usually by November or December, you're seeing male patients. We have 1 therapist on our faculty who kind of is developing a clinical practice towards pediatrics, and Dr. Jennifer Miller. And so Jennifer's the first residence, the first mentor in the first 6 months of the residency. And so we try to get some pediatric exposure at that time while Jen is working with the resident in order to kind of demonstrate how you can apply the principles to the kids. But I would say that that's probably 1% of our population. So you might get to see a child that is on your caseload for the whole time. We don't have a huge pediatric caseload.
Okay. And are there any international opportunities, either the residencies going abroad or maybe other people coming from abroad to the university that the residents would be able to work with?
Right now, I have not ever taken a resident with me whenever I've traveled to Ethiopia or Niger for the work that I do. That doesn't mean that won't happen in the future. I did offer potentially to do something with the current resident, and told her that it would have to be a choice between going to combined sections meeting or going with me to do a surgical trip in Ethiopia, and she chose the combined sections meeting, which I think was a smart choice on her behalf, because that's your time for networking, meet the tribe, get to understand, what are the volunteer activities within the section, and many times the residents come here to train, but they don't stay here. They go on to other places. And so it's a time to meet potential employers and kind of get a feel for what are other variances in the practice of women's health. So I thought it was a really smart choice on her behalf to say no to coming with me at that time. So the future is one of those things with me personally setting up international things that it will always be an option. But I don't ever know from year to year what the needs are going to be. My hope is that we will develop some kind of a strong commitment that the resident post-residency can be plugged into, but that still hasn't happened. This year we're actually bringing a physical therapist from Ethiopia into the country, but it's a male, and he is someone that we're hoping will become the director of the educational program in Ethiopia. We wanted to provide him with a broad scope of what physical therapy in general can do, and so educating a women's health therapist has always been done kind of on site instead of bringing them into the country. So we don't have a current exchange program set up at this time, but you never know. There's potential.
And you talked about the basic work after the residency. How many residents have come to work for your hospital system?
One.
Most of them just go back home or
Well, we have one that actually we trained her, and now she works for a competition. And she's doing a great job. So our a competing clinic within our health system have opened an office in the south part of the city, of the county, actually, St. Louis County, and Christina Dolan is working for them, and she still comes in and teaches, and we still interact. So we would love to not have that happen, but we can't, we can't help that.
Okay, and can we talk more about the application process? Is there maybe the application cost, or is there a tuition cost that comes out of the salary?
We don't currently, and I say that because things can change, because we haven't had our meeting to discuss the financial impact of this year on next year, but we currently don't charge the resident tuition. Their salary is a 3/4 entry level salary for our region. So you're being paid at a lower rate than someone who would be coming in out of school in order to try to offset the costs of the education. We've worked really hard to try to make our residency profitable, and we might actually achieve that this year. So it's taken a while to get it right in order to at least run in the black. We've been running in the red many years, and so education is definitely expensive. So that's why I don't know if there's always that option that we may charge tuition in the future, but we currently don't. So you get paid a little less than the average entry level person to work a lot harder, because you're doing all this learning on top of all of the caseload. So that I think the payoff right now has been good for the resident, that they felt like the value was well worth the education they were getting.
Okay, and can you tell us about the interview process?
Sure. So we review, all our applications are due January 1. Within 2 weeks, we try to meet and review all the applications. We usually interview the top 4 candidates and try to bring them into St. Louis. Our interview day for 2018 is February 2nd. And so that would be the day that you would be coming in. It's a Friday. You would be coming into St. Louis in 2018 if you applied for the residency. You would have a half-hour meeting with any one individual that is part of the review board. So actually with me, I usually end up spending a full hour with the resident, because I get a half hour with them one-on-one, and then I spend time in the morning orienting all the residents. We bring everybody in, but you all get individual interviews. So we don't do a group interview. We have individuals kind of meet with each of the key players, and at lunch you get to meet the current women's health resident. We usually have that during the lunch, that you guys, the interviewees, have lunch with the resident so they can pick her brain and ask questions. And then within 2 weeks of that day, we let everyone know that we have either sent an offer to you, or we have decided to choose another candidate. Now, that's the most painful thing that I ever do, because usually everyone that comes in the door is wonderful. I've yet to interview someone and go, oh my gosh, you're going to be a terrible women's health clinician. I haven't seen one of those yet. I'm honestly telling you that if I could train everyone that came in the door, I would, but I can't. So it's a hard decision. So that's why it helps to have a team of people.
And you said that, Joe, it's January 1 January to 2 February. When do you find out if you were selected for the interview?
Within the 2-week window after that. So we have like a 2-week window that we deliberate and then decide.
Okay. And in your opinion, what would make a good candidate stand out? Maybe from the 4, or even from just the application process?
Sure. So when you're writing your essays, trying to convey the passion that you have for women's health and demonstrate the breadth of experience that you've done to try to learn about this passion. So building a CV, so to speak, of engagement in some way where you had experiences that kind of really led you to decide that this is the thing for you. So we do require that you take a pelvic health course. It doesn't have to be that you take it by the time you apply, although that does definitely help. But by the time you start the residency, you have to have had a level 1 pelvic health course. But we really like to be able to have you reflect over that experience to make sure that this is for you, because you don't want to sign up for something that then you get halfway through it and go, I don't want to do this. We want to choose candidates that are, one, going to make it all the way through, but two, really speak to the passion as to why they want to become a women's health clinician. It's not always easy. You have to commonly be the first follower, the first person that goes and says, yes, I want to do this, and open your own clinic. And so we're always looking for that independent spirit, kind of an entrepreneurial person, so to speak, that can think on their feet and is willing to go that little extra mile in order to promote, support the concepts that we're trying to develop, and really it is going to contribute to the profession in some way. So we're looking for all those things. So we've had residents be the treasurer of the section. We've had residents be the educational coordinator for the section's women's health educational program. We've got 2 residents that have published. We want to develop leaders, so we're looking for skills that will be able to show that while you go through this process, when you leave, you're going to be a leader in some way related to women's health.
And do you think that there's a best time to do a residency, either right after school or after having some clinical experience?
Right now, I think the benefit of the residency program is a right after school experience. I have not had the opportunity to train someone who has had some experience and then joined the residency. And partially it's because most of the candidates that we've interviewed who have had experience are already doing all of the things that we would be doing with the residency. So they're engaging in interdisciplinary clinics. They've gone and observed, with specialists in their community. They've marketed services to physicians groups or nurse practitioners groups, and so they're doing it, and they're building their network. And if you pull them out of their network where they are, then they don't have that year of growth in the network. And so finding a mentor is what I usually advise people that have been out there. Find a mentor in the network that you've already started to establish. So it's a conundrum, because honestly, someone who has a year of experience is going to hit the ground running, because they won't have to do all those things that a new graduate has to do. Is how do you get to work on time? How do you keep your schedule straight? How do you communicate with the front staff when there's a scheduling error? All those things that are like, you have to go through that process of learning how to be a good citizen in the clinic. It's already been tackled by the first job that they had. So I do think that the training is more conducive to a new grad. I would love to take someone who isn't a new grad, but we just haven't done it, because every time I talk to them, I'm like, you're already doing it. Come on, go. So that's the hard part. New grads really need a leg up. They need a way to kind of jumpstart to get them where so that they can have the confidence to march into a new health system and start a program, or they can have the confidence to jump into an, like a very busy private practice, say in the Chicago area, which is one of our residents did, and have the confidence to be able to do the work and compete and make the decisions and be productive. So there, I'm a little bit, our bias is new grads, and now you know why.
And how many residents do you accept each year?
One. Right now we're just training one.
Just one.
We just got our 10-year accreditation, so I can kind of relax a little bit on the structure that we have right now and start thinking about the future. And so I'd like to train more. I'd like to get through this year of kind of understanding the new guidelines for the residency. So there's been some new guidelines that have been published. So I have kind of this grace year that we get to use our accredited curriculum as it stands. And then for 2018, we'll be starting to really think about the future. So that maybe in 19, maybe in 20, we'd set something in place where we had a distance student that was not on site, but that was actually an employee of an off-site area that was then coming in for didactic. But I don't really know how that is going to pan out yet. I always say I don't know how the golf course is laid out yet, so I don't know which direction I'm going to hit the ball. So, so I kind of have to go, I would like to train more. It's our future. We're not there yet.
Okay. And how many of your residents have passed the WCS?
All of them.
All of them? Okay. And
no problems there.
No problems there. That's great.
Yeah.
So could you tell us more, what do you think your program's biggest weakness / biggest strength is?
Our weakness. I think our biggest weakness is that we aren't in inpatient yet. And I think that there's a rich environment for women's health clinicians to see women in the immediate postpartum phase before they're discharged from the hospital. And I think this is a public health issue, not just a residency weakness issue. I think across the United States, all women should have their belly, backs, and bottoms assessed by a PT before they go home, so that they can have a more successful first 4 weeks of working with their newborn and transitioning to being a mom. I think we, as physical therapists, have a lot to offer, and that is one of those things that I really feel is important, that we need to keep pushing to try to get into that environment of that practice setting, so to speak. So I think one of our weaknesses is that we're not in the hospitals, and that would be pie in the sky. But I do think that with patience and due diligence, we can all strive to do this. So that's one of those things that I think we could grow with. I think one of our strengths is our mentors. I have very experienced, well-trained women that I'm working with. They're great communicators. The resident has multiple points of touch by the women's health faculty, be it that they get mentored just specifically in their movement skills, or they get mentored in their lymphedema skills, or they get mentored in their pelvic health skills. So I think that we have become extremely responsive from a communicative need of, you sit next to a former resident who is also your mentor. In the clinic, you have an open door policy with me and the director. You have a third person that you meet with in the first half for 2 hours every other week to work on your movement skills. So I do think that we've really tried to pad that communication so that we're responsive to the mentor's needs. The other thing that I think is very unique to our program compared to other programs is that we use movement as our guiding principle. And so from the top down, from the minute you see the person walking in from the waiting room to how they're sitting in their chair, to how they're gesturing with their head, whatever it is that are their movement habits, you're going to be able to learn how to interpret that into, is this feeding into the pain syndrome that they have? And I think that is the future of our profession. We are movement specialists, all of us. And so I think that that's a benefit. The resident gets a movement fellowship training, so to speak, because they train with the same material that the fellows do, only they're getting it earlier in their career. So they're getting it at that more younger part of their career so that they can then push those movement concepts for their patients.
Okay. And can you tell us more about the location of the residency?
We're located in St. Louis, Missouri, down in the downtown area, right next to Forest Park. The residents have lived in a variety of areas, all within, some of them within walking distance, some within the Metrolink train line distance from where we are. We have a wonderful arts district in the St. Louis area, and then the Loop, which is over by Washington University itself. So our main campus is on the other side of Forest Park from us. And the clinic that the resident practices in now is part of the faculty clinic. We are all housed within the physical building of the physical therapy school. So it makes it very easy to transition to heading to a classroom to help with a lab, or giving a lecture, because you're literally maybe one door away. So you see a patient, grab your computer and walk down the hallway and you're in the classroom. So that's really nice that that's all kind of in one area. So what else about where we are?
Oh, that's everything. Those are all the questions.
All right.
A lot of information out of you. All right. Thank you so much for doing this interview with us.
Oh, absolutely. Best of luck on your applications, and maybe I'll see you all at CSM.
All right. See you.
Okay. Bye.